On this episode of the show, I have with me Yulin Wong. He is executive chairman and co-founder at Servato Health, and we're going to be talking about, well, a little bit about his background and also the emergence of robotics within medicine. And he's got a very unique background, Yulin does, and we'll talk about how all that came together to find where he's at now, and talk a little bit about how the future of medicine looks with robotics and some AI and what technology is going to enable us to do. Got a lot to cover, but Yulin, thanks for taking the time.
Thanks for having me, and Happy New Year.
Absolutely, you as well. All right, before we start, set some context for everyone. Servato Health, what do you guys do there?
At Servato Health, we're targeting the problem that you don't have high quality access to healthcare procedures everywhere. You basically have these procedural experts, whether they're surgeons or interventionists or diagnosticians, and they're usually clustered around metropolitan areas, but then populations live all over the place, throughout the metro area, the suburban area, the rural areas. And we develop the technology that allows these new types of robotic tools, whether they're there for surgery or interventions or even diagnostic procedures, they can be done at distance. So a surgeon can be in one location, a patient can be somewhere else to still get the benefit of that surgical expertise.
Absolutely. And I guess we'll kind of get into more of that space as well. But I guess we'll go back a little bit and talk about your background, because you have spent some time in tech, and obviously you've picked up different areas of expertise, and obviously we'll talk about where you're at now. But give us a little background in terms of your voyage through tech and the healthcare relationship as well.
Yeah, so going all the way back to schooling, I'm an engineer as opposed to a medical doctor. I have a PhD in robotics. And then I started my first company. This is in the beginning of the 90s. It was called Computer Motion. Computer Motion was the first company to do surgical robots. And it ended up going public in 97 and then merging with Intuitive Surgical in 2003. But before that merger took place, I was involved in leading a project where a Professor Jacques Maresco, a general surgeon, sat in New York City and operated on a patient in Strasbourg, France. So surgeon was on one side of the Atlantic, patient was on the other side of the Atlantic, did a gallbladder removal successfully. And that was done in September 7th, 2001. So then when Computer Motion became part of Intuitive in 2003, I remembered that procedure and thought, boy, isn't it fantastic when you can take healthcare expertise and transport it? And the timing wasn't right yet to do telesurgery, but I thought that telemedicine could become a big deal, and I started a company called InTouch Health. And InTouch Health started in 2003, and it was focused on just enabling telemedicine. Telemedicine, where a doctor talks to and interacts with a patient from afar, but can't do anything, can't touch the patient at all. Just kind of through audio and video communicates and pulling of data, images, and stuff like that. So, for example, InTouch, one of the key use cases was telestroke. So a stroke neurologist would be taking care of a patient at distance who was suffering from a stroke. And so that company grew to become the dominant telemedicine company for health systems, and it was acquired by a company called Teladoc in 2020. So now COVID's happening in 2020, and it's pulled telemedicine forward, where pretty much everybody, I think, knows what telemedicine is today. And then in 2021, myself with my co-founder, Cynthia Perazzo, started going, well, maybe now 20 years later from the Lindbergh operation or that transatlantic surgery, it is time for telesurgery. And that's why we started Servato.
I love it. I mean, obviously, as you just described, you had a very clear vision of technology's role within healthcare, within the medical space. Was that opportunity? And you saw this long ago. Obviously, you talked about the surgery across the water. What was it that you saw early that gave you that, the vision of where the future technology and the impact in healthcare could be?
Even back in the late 80s when I was actually still in school, the news about healthcare was costs are going through the roof. We're not going to be able to sustain it. It's not distributed equitably. It's the same things which we're hearing today. Okay, so unfortunately, we haven't solved the problem yet. But the one thing which is different about healthcare than most other products is quality healthcare actually costs less. Like if you want a higher quality car or audio system or something like that, generally you pay more. But healthcare, higher quality, if done right, costs less. And so, and how is high quality care delivered? Usually, it's getting the right expertise to the right place at the right time efficiently. And that's effectively what, my whole career has been during this whole transition and full adoption of the internet. So you start back in the early 90s and then you kind of keep going forward. And so the internet has created a mechanism to distribute expertise. And then you combine that with robotics, that gives you the mechanism to do something to someone at distance. So you combine the internet with the robotics, and you basically can now bring the right expertise to the right place at the right time. And that implies higher quality, quite honestly implies more access, easier access, all of these things. And that should drive costs down. And so that's pretty much been the whole evolution of my career.
Absolutely. I guess, we do watch a lot of movies here, and we see the science fiction side of this stuff. And I think that sometimes taints the expectation of where reality is. It is a process you have to follow. If you were to kind of look at what was impossible, or not impossible, which was something that was very difficult, and now we are seeing opportunities to deliver on some of that vision, where are we on that timeline? Are we still, obviously we're further along than the surgery you mentioned 20 years ago across the Atlantic, but are we still a ways away from having that distributed model so that a surgeon doesn't have to be next to a patient? How far is that timeline?
Well, if you think about just telemedicine, first of all, the company which acquired my company InTouch, Teladoc, does 40 to 50,000 telemedicine consults a day. So that's just one company, and so it's happening a lot. So now if you progress to like surgery or something like that, quite honestly, more of these procedures are being done out of the U.S. as opposed to in the U.S. today, largely because of regulatory challenges. But we're in the call it one a day type of worldwide thing. So it's very, very early, but it is such that telemedicine, it took quite a while for society to become comfortable with it. But now that the society is comfortable with telemedicine, once all the technology infrastructure is in place to be able to, and capabilities to be able to do remote surgeries, I think that's the adoption curves, excuse me, is going to be much faster.
That was actually, I guess, the reason I was asking the question was exactly what you alluded to, is just the adoption rate. And this is one of those areas where the growth of telehealth, you mentioned it was pulled forward through COVID, where we're more comfortable being on Zoom. I think traditionally people think of surgeries as I walk into this building and there's a surgeon comes in, talks to me and does all that. if we're talking about, and this is, I guess, just putting your lens of what happens in the future, what would that look like? Because I think a lot of us who haven't gone through what that model looks like probably are thinking certain things. But I guess you've envisioned this for a long time, and you're at the heart of it. But when we do think about a surgical robot component, what's that going to look like for the patient?
Yeah, so first let me explain the configuration of surgical robots. There are always two pieces to it. There's the side which almost looks like a very advanced video game, which the surgeon sits at. And there's the side which generally has robotic tools. They could be robotic arms or what have you that operate on the patient. And the two sides are connected by cable. And that cable is typically 20 feet long. And that's the distance which you can separate the two sides. So what Silvato's doing is taking out that 20-foot cable and putting a whole platform of technology so that the two sides can be spread 200 to 1,000 miles apart. And so that's what enables the remote side. Now, as you mentioned a second ago, patients go into hospitals and they get their operation. That concept's probably not going to change, and not at least for a long time. That's not going to change. Patients still going to go to the hospital, but the patient, instead of needing to travel hundreds, maybe thousands of miles to get the care they want, who has the expertise that they want, okay, they could go to their local hospital. So, for example, 25% of this population, of the U.S. populations, live in rural areas, which are generally served by 1,300 critical access hospitals. Critical access hospitals have 20 or 25 beds or less, so they're really small. They generally don't do surgeries, or definitely don't do complex surgeries. So therefore, that requires 25% of the population to drive generally far away to not where they want to go, because they're not familiar with the area. They can't go home easily. They have to stay in hotels if loved ones stay by. It's very, very inconvenient, frustrating, and quite honestly, stress building. But if you can actually bring that expertise from the big cities into the rural area, and then have that local team surround that patient to help take care of them pre and post-operatively, then you can actually have that patient stay in the local community, get the best type of expertise, and then go home. And it's actually it's kind of a win-win-win, because it's a lower cost center, should lower cost, higher quality care, therefore better outcomes, should lower cost, makes it more convenient for the patient and the patient's family by staying in their local community, and keeps their local community healthcare system, very small hospitals which generally have a hard time staying in business, helps them keep enough revenue to keep them going. So it's really a very helpful capability to the overall system.
I love that. And when we spoke about this, I actually had some time to think about this. I actually had both my hip labrums repaired, and they give you the images, and you get an idea of how this arthroscopic surgery looks like. And I was just thinking to myself, just between when we first spoke in our recording session, I was like, well, the surgeon's operating these tiny little things, doing this microscopic, to me, surgery, wire. And I'm like, well, what if a robot did that and he wasn't there? And I'm a part of a community that on Reddit that talks about this surgery, because it's not common. And some people in communities that you just mentioned, they have no access to surgeons who perform this more than once in their life. And the outcomes are different, because my surgeon, I'm in a big metro area, he does hundreds of this a year. He's an expert at this. But you go to a normal orthopedic surgeon and he tries to fix a labrum, he just might not have the latest protocols or know how to go into the tissue versus a doctor who does it all the time. And what you just said, it just resonates in how that quality of care is so different when you do have different levels of access.
Well, so you hit on the key metric which determines clinical proficiency, which is how often do you do it? It's very, there's no single metric which answers it all. But if you were to get a procedure done yourself, what's the first question you ask the person who's going to do it on you? How many times have you done this? How many times have you done this over the last year? It turns out, as you know, I mean, by obvious reasons, half the surgeons out there are below average. And why are the ones below average? Typically, it's because their volume is much lower. I have a friend whose wife had throat cancer in a rural area of Montana. She had it operated on in that general area. It's an affluent area, so it's not a money issue. And unfortunately, she died a few days later because of surgical complications. I looked up to find out what the volume is in that area. In that area, catchment area, they do maybe the total area, not just for a particular surgeon. The total area has maybe 6 throat cancer procedures a year. So there's no way that should be done there because there just isn't the volume to be proficient. So wouldn't it be great if you get the expert who's doing 200-300 a year from one of the larger medical centers to be able to beam over there to do that procedure? That's what Savato offers.
That's I mean, that's very unfortunate, but also ties into the conversation because you said quality healthcare can actually lower costs, and I think a lot of people might hear that. And you mentioned the reference to cars, and we're starting to think about a surgeon and their time. If you ever gone into seeing a surgeon, they have a very particular schedule. They're in there for baseline time. They get their questions. They're out. They have a if they're a bigger staff, they have a physician assistant that's trained that handles a lot of your care because their time has to be spent in surgery. We get that. I guess to distribute this skill, this talent, this ability, this repetition, right? As you just alluded to, all these different factors across a wider gap. I guess as you look at that and you go, well, if we're going to start spreading that time out, the doctor's time, are these surgeries becoming just more efficient and they have more time to potentially do more? I guess where do they get the time back? Is there a time component, or is it just the more knowledge distribution?
So first off, the persona or personality of a surgeon generally is what they love doing most is surgery. Okay, so that's what they hate the most is administrative paperwork. So there's a lot of technology going on in order to help reduce the time in which someone has to do their administrative paperwork. Hopefully that continues and is successful. But if you take a standard operating day and you basically take an operating room and figure out how that operating room is used to 100% of capacity. It turns out our chief medical officer, Dr. Dennis Fowler, was head of perioperative services for New York Presbyterian Hospital in New York City for 6 years. And so that's the person who's in charge of the operating room schedule. And they have, I don't know, something like 60 operating rooms in that hospital. It's a big one. So if you take a typical operating room and you carve up how much time is being spent actually doing the surgery versus how much time is being spent wheeling the patient in, putting them under anesthesia, prepping the patient, then you do the surgery, then afterwards taking the patient, bringing them out of anesthesia, taking them out of the room, cleaning the room, and you take all those components into your workflow. It turns out more than half the time is spent doing the non-operating part. Because you can imagine cleaning a room is no simple thing because, especially to the sterility requirements of operating room, taking a patient, putting them under anesthesia, taking them out of anesthesia, opening and closing the patient. Those are a lot of very critical steps. So it's not like they're wasting time. It's just what you need to do. But the surgeon's time is less than half the time. So with Savato, our belief is that surgeons can operate at least twice as much. So they can operate, there's other people to do these other tasks, and then they can operate in different places, in geographies, and double the productivity, which again is another huge benefit to society, because one of the biggest challenges in our health system too is the shortage of physicians and surgeons of particular specialties, pretty much all of them. And so that's I think how time is freed up.
Absolutely fantastic. And I guess, I know we're running out of time. I could ask you questions probably for a lot more than the half an hour, but I guess one final question would be, is the surgeons themselves, obviously they go through years of training. They have gone through the process you just described. Their world would be shifting a bit. They get half their day back, as you mentioned, and they are operating a little bit differently. When we look at the change that they're going to undergo, I mean, the training for the last 50, 70, 100 years of medicine, I mean, obviously it's evolved, but generally they have to be there. I mean, that's been what we've seen. What's going to have to change for surgeons now in the future to, as this robotic component grows, what are the changes they're going to have to go along with?
First of all, change is one of the hardest things us humans do. So, and surgeons, they perfect their craft by doing things exactly the same way every time. So it's a non-trivial thing to basically change behavior in this manner. The behavior change is actually to embrace this type of change is much more than just the surgeon. It's the health system, and the health system needs to enable these workflows to take places. It turns out in the U.S., most hospitals are not singular hospitals, but are part of a group of hospitals, generally called an IDE, independent delivery system. So there are groups of hospitals, and generally these groups of hospitals have one or more of the bigger flagship hospitals and many more of the smaller community or even critical access hospitals. So what the health system needs to reimagine themselves is one in which they can deploy all of their expertise with no geographic boundaries. And that's actually, and then getting their surgeons on board with that. And so when you do that, they will be able to better serve the populations they serve, as well as actually, it turns out it drives better financials, better profitability, better margins by better leveraging the scarce or limited expertise they have in some small number of their locations across the whole system.
Absolutely. Very interesting. I can't, we're going to have to do one of these as a follow-up with you in a couple of years to see how far along we are and what has changed. But Yuland, I appreciate your time and sharing with us. If somebody does want to learn more, we covered a lot of different areas. If somebody who has a follow-up question, what's a good way of doing that?
Well, so I'm on LinkedIn, and then also my email address is ywang@savato, SOVATO.com.
Absolutely. Again, thank you for your time. I appreciate it.
Thanks for having me, Amir.
Absolutely. All right, that's it for the episode. Be back again, different guest, different topic. Until then, two things. One, love it if you guys would share this episode. Thought it was fantastic. We talked about Yuland's background and how tech and healthcare have come together, a vision that started a little while ago and has now grown and is still growing, and still more room to grow to come. And Savato is doing some pretty exciting stuff. And please share this with somebody who will also be interested in learning more. I'd like that a lot. Also, like, subscribe, comment. Let me know how the show is going for you. Until next time, thank you and goodbye.